Welcome to the Funnel Effect. Today, we are undertaking a critical deep dive into a clinical challenge that is really defining modern interventional cardiology. How do we safely and effectively treat arteries that have, well, essentially turned to stone?
Yeah, exactly. We're dissecting the comprehensive guidance from a really important document, the SCAI Expert Consensus Statement on the Management of Calcified Coronary Lesions.
SCAI being the Society for Cardiovascular Angiography and Interventions.
Right. And this statement is quite a landmark because it pulls together years of experience, trial data, all the collective wisdom, into actionable steps for managing what is probably the trickiest type of coronary artery disease.
And the group behind this guidance, it's a who's who. We need to make sure you, our listener, appreciate the level of expertise here. The authors are Riley, Patel, Abbott, Bangalore, Berlakis, Croce, Doshi, Call, Kearney, Kerrigan, McGettigart, Maihara, Reimer, Sutton, and Shaw. Just an incredible panel.
Absolutely. Their consensus really forms the blueprint for procedural success in the cath lab today when you're facing significant calcium.
And we need this blueprint, right? Because the technology is moving so fast.
It really is. I mean, historically, these heavily calcified lesions, they were often procedural failures or led to poor outcomes. Now we have this expanding arsenal of tools, specialty balloons, different kinds of atherectomy, intravascular lithotripsy.
A lot to choose from.
A lot. But knowing when to use which tool and how to use it precisely, that requires clear guidance, standardized criteria, which is what this document provides.
Okay, so that brings us squarely to our mission for this deep dive. For you, the listener, the context is this. The prevalence of calcified coronary artery disease, CAD, it's rising. And that makes percutaneous coronary intervention, PCI, much, much trickier.
Definitely. You're looking at increased risks across the board. Short term, things like dissection, perforation, vessel injury.
And long term.
Long term, it's things like stent thrombosis, which is catastrophic, and restenosis, the blockage coming back inside the stent. These are significantly higher with calcified lesions.
So our goal today is to really distill this expert consensus. We want to break down first, how do you actually identify these challenging lesions accurately? Because just looking at the angiogram isn't enough.
Not even close. Second, we need to analyze the specific types of calcified lesions, these morphological subsets, because they behave differently and need different approaches.
And third, map out the toolkit. Understand the mechanics of each device. The balloons, the atherectomy systems, the lithotripsy, so you can choose strategically and crucially, prepare the vessel properly before the stent goes in.
That's the absolute key takeaway from the consensus, optimal vessel preparation. It's the single most important factor for long-term stent success in these really tough cases.
Okay, let's unpack this. Let's start by really grasping the scale of this problem. How common is this and why is it becoming more common?
Well, the numbers really tell the story. Coronary artery calcification, or CAC, isn't some rare thing. It's fundamentally intertwined with how atherosclerosis develops over time.
It's part of the disease process itself.
Exactly. And what's striking is how it tracks with age.
Right.
It really starts to increase quite linearly in middle age. By the time individuals reach 80 years or older, CAC is almost universal. It's just there.
So with populations aging globally, this isn't just a problem. It's becoming the standard challenge in the cath lab for older patients.
Pretty much, yes. And beyond age, there are specific factors that really accelerate this calcification process. The consensus document lays these out clearly.
What are the big ones we need to look out for?
Top of the list, you've got chronic kidney disease. That's a huge driver. Then diabetes mellitus, hypertension, especially if poorly controlled tobacco use, a high body mass index, chronic inflammation from various sources, and of course, a strong family history of early heart disease.
So the usual suspects for cardiovascular risk, but they specifically ramp up the calcification aspect.
They do. They create this environment in the vessel wall that's, let's say, permissive for calcium deposition. You get damage, inflammation, and then these hydroxyapatite crystals start to deposit.
And it's not like it forms in one uniform way, right?
Yeah.
The structure of the calcium itself matters a lot for how we approach it.
That's a critical point. The morphology, the structure, dictates the challenge. On one end, you might have microcalcification. These are tiny specks, less than 50 micrometers.
Sounds almost insignificant.
You'd think so, but paradoxically, they're often found in unstable, vulnerable plaques. They might cause these tiny ruptures in the fibrous cap, suggesting an active, inflamed lesion. Not necessarily hard to cross, but high risk.
Okay, so not a mechanical barrier, but a biological warning sign.
Precisely. Then you move up to fibrocalcification. Here, the calcium is more organized, forming larger sheets, but it's still kind of embedded within the plaque itself.
Getting tougher?
Getting tougher. And then you hit the real mechanical nightmares.
Yeah.
Dense sheets of calcium, often wrapping around a significant portion of the vessel, sometimes the whole circumference, or these things called calcified nodules.
Nodules sound particularly bad.
They are. It's a chunk of calcium that actually protrudes like a rock into the lumen, into the flow channel. Very difficult to manage.
So let's connect this morphology to why PCI fails. Why does this hard stuff cause so many problems for stents? It's not just about getting the stent to the lesion, is it?
No, delivering the stent can be tough, sure. But the main failure mechanism, the one that drives poor long-term outcomes, is stent underexpansion.
Meaning the stent just doesn't open up fully.
Exactly. The calcium is rigid. It resists the outward force of the balloon expanding the stent. So the stent struts can't reach their intended diameter. You end up with a smaller final lumen, higher shear stress at the edges.
Which triggers restenosis, the blockage coming back.
Precisely. And often going hand in hand with underexpansion is malapposition.
Malapposition. The stent struts aren't snug against the vessel wall.
Right. There are gaps left between the stent and the wall because the calcium holds it off. These gaps are zones of stagnant blood flow, perfect breeding grounds for thrombus blood clots. That's a major driver of late stent thrombosis.
So the calcium basically creates this hostile, unyielding environment where the stent just can't do its job properly.
That sums it up perfectly. It acts like an external clamp resisting the stent's expansion.
And the clinical bottom line, as the consensus stresses, is higher rates of MACE, major adverse cardiovascular events. We're talking heart attack, repeat procedures, even death.
Absolutely. Target vessel failure, stent thrombosis, in-stent restenosis, all significantly increase compared to non-calcified lesions.
It really forces a shift in thinking, doesn't it? The intervention isn't just stenting anymore.
It can't be. It has to be a two-step process, really. Step 1, modify the calcium, prepare the vessel optimally. Step 2, then deploy the stent. You absolutely cannot skip step 1 in these cases and expect a good, durable result.
And step 1, modifying the calcium, relies entirely on knowing exactly what you're dealing with. Which brings us to imaging.
This is probably one of the strongest messages in the consensus statement. Relying solely on angiography, the standard X-ray pictures to assess calcium and guide treatment is just insufficient.
But wait, angiography can see calcium, right? You often see those radio-opaque lines along the vessel. It has high specificity. The experts say if you see it, it's definitely there.
True. Specificity is high, around 95%. If angio shows calcium, you believe it. The massive problem is sensitivity.
It misses a lot of it.
It misses half of it. The consensus quotes studies showing angiography sensitivity for detecting significant target lesion calcium is only about 50% compared to looking inside the vessel with imaging. So you could be treating what looks like a soft plaque on angio, but inside there's a ring of calcium waiting to prevent your stent from opening.
And even when angiography does see calcium, it doesn't tell you much about its characteristics, does it?
Exactly. That's the second major limitation. And angiography is a 2D shadowgram. It can't tell you if the calcium is just on one side eccentric or all the way around concentric. It can't tell you how long the calcified segment is accurately. And crucially, it tells you absolutely nothing about how thick the calcium is.
And thickness seems key.
Thickness is everything when it comes to predicting how the calcium will respond to treatment. Is it thin and likely to crack, or thick and rock solid, needing serious firepower? Angio gives you no clue.
Okay, so that's the case against relying only on angiography. What about the solution? Intravascular imaging, IVUS, and OCT.
Right. Intravascular ultrasound, IVUS, and optical coherence tomography, OCT. These tools are increasingly recommended, moving from optional to almost essential for complex PCI. The major guidelines, SCAI, give them a Class 2A recommendation for complex cases, specifically to reduce ischemic events.
Let's compare them for calcium assessment. Both are good at detecting it, measuring the arc, the length.
They both have excellent sensitivity and specificity for detecting dense calcium, over 90%. They both allow you to measure how much of the vessel circumference is involved the arc and how long the calcified segment is.
But there's a crucial difference.
The crucial game-changing difference is resolution, which translates directly into the ability to measure calcium thickness.
How do they look different inside the artery?
IVUS uses ultrasound. It penetrates tissue well, doesn't need blood cleared. Calcium shows up as bright white echoes, often with a dark acoustic shadow behind it because the ultrasound can't penetrate the dense calcium. It's great for seeing the arc in length.
And OCT.
OCT uses near-infrared light. Its penetration isn't as deep as IVUS, and you need to clear the blood with contrast or saline to get clear images. But the trade-off is incredible resolution, almost microscopic.
How does calcium look on OCT?
On OCT, calcium appears as this signal-poor heterogeneous area, but with really sharply defined borders. Because the resolution is so high, you can place calipers on those borders and accurately measure the thickness of the calcium layer.
And that's the measurement IVUS struggles with.
Exactly. IVUS can't reliably measure thickness because of the acoustic shadowing and lower resolution. OCT's ability to measure thickness is its killer app for calcified lesions. It tells you just how formidable that calcium barrier is.
So, knowing the arc, length, and now thickness, how did the expert group translate these measurements into practical rules? When do you absolutely have to modify the lesion before stenting?
They established consensus criteria based primarily on predicting stent underexpansion. Essentially, if your intravascular imaging, IVUS or OCT, shows any one of these three features, modification isn't optional, it's required.
Okay, what's the first criterion?
The most obvious one, a 360-degree arc of calcium. If the calcium completely encircles the vessel lumen, there's nowhere for the stent to expand easily. Modification is mandatory.
Makes sense. What's the second?
Second, if you have a calcium arc greater than 270 degrees, so most of the way around, and that segment is 5 millimeters long or longer. This defines a substantial rigid tube that will resist expansion.
So even if there's a small gap, if it's long and mostly calcified, you modify.
Correct. And the third criterion relates to vessel size. Modification is recommended if calcium is present, even if it's not circumferential, in a vessel with a reference diameter less than 3.5 millimeters.
Why specifically in smaller vessels?
Because smaller vessels have less compensatory capacity. Even moderate calcium in a small, stiff vessel, especially one showing negative remodeling, can significantly impede stent expansion. The consensus really flags these small calcified vessels as high risk for underexpansion.
And then there's that unique OCT measurement, thickness. You mentioned the 0.5 millimeter threshold. How does knowing the thickness guide the interventionist?
This is where imaging directly dictates strategy. It's like knowing whether you're trying to crack a thin sheet of ice or a thick block of granite.
Okay.
If the OCT shows the calcium is thick, let's say, consistently 0.5 millimeters or greater, it's going to behave like ceramic. It's hard, brittle, but strong. It will likely require significant energy to fracture it, think rotational or orbital atherectomy, or the sonic pulses of lithotripsy.
And if it's thinner than 0.5 millimeters?
If the minimum thickness is less than 0.5 millimeters, the calcium behaves more like, say, a thin, brittle piece of plastic. Studies have shown these thinner segments are much more likely to fracture with less aggressive measures.
Like high-pressure balloons.
Exactly. High-pressure non-compliant balloons, or cutting and scoring balloons, often have enough force to crack these thinner segments. So knowing the thickness allows the operator to potentially start with a less aggressive, often safer modification tool first. It avoids bringing out the heavy artillery unless absolutely necessary. It's really about tailoring the force to the resistance.
That's incredibly precise. It moves treatment from guesswork to targeted therapy based on the lesion's actual structure.
That's the whole point of the imaging-guided approach advocated by the consensus. Know your enemy in detail before you attack.
Okay, so we have the measurements. But the consensus also highlights that different types of calcified lesions pose unique challenges. They identify 5 specific subsets. We absolutely have to start with the calcified nodule, the CN. These sound particularly troublesome.
They really are. A calcified nodule, or CN, isn't just a layer of calcium. It's a distinct, localized mass of calcium that actually protrudes into the lumen. It has this convex, rock-like shape sticking out into the flow channel.
Where do you typically find these?
Their overall prevalence in all blockages is relatively low, maybe less than 5%. But, and this is key, they are highly concentrated in the most severely calcified vessels. If you have a lesion with more than 270 degrees of calcium arc, the chance of finding a CN jumps to over 30%.
And they're linked to specific patient types.
Yes, you see them more often in patients with chronic kidney disease, especially those on hemodialysis, and interestingly, in patients who have had previous coronary artery bypass graft surgery or CAVG.
What makes them so dangerous for long-term outcomes? Why the higher risk of MCE and restenosis?
It's down to their mechanical properties. When you deploy a stent over a CN, the nodule resists compression because of its rigid convex shape. You might achieve okay expansion initially, but over time, the internal stress often causes the nodule to essentially push back, to re-protrude through the stent struts.
Like a bulge growing back inside the stent.
Exactly. This re-protrusion creates a new blockage, triggers inflammation and neointimal growth, leading straight back to restenosis. It's a mechanical failure mode that's really hard to prevent without addressing the nodule itself.
So treating a CN isn't just about cracking calcium. It's about changing the geometry, flattening that protrusion. How does imaging help here?
OCT is invaluable for CNs. It can differentiate between two subtypes. There are eruptive CNs, where the surface looks irregular, the fibrous cap is broken, maybe there's thrombus attached. These are more unstable, associated with worse outcomes.
Of the other type.
Non-eruptive CNs. These still have a smooth fibrous cap covering them. They might allow for slightly better initial stent expansion, but the risk of late reprotrusion is still there. Knowing the type helps gauge the risk and decide how aggressively you need to modify, often requiring atherectomy to physically ablate or flatten the nodule.
Okay, moving from nodules to length, long calcified lesions. Is this simply a case of needing a longer stent and maybe more modification?
It's more complex than just length. Yes, the longer the segment of severe calcification, the higher the risk of uneven or incomplete stent expansion somewhere along that length. But the critical insight from the consensus is this. The tightest part of the blockage, the minimal lumen area, might not actually be at the same spot as the most severe calcification.
Ah, so you could have a long lesion that's tightest in one spot, but the rock-hard calcium is somewhere else.
Precisely. Imagine a 40-millimeter lesion. Maybe the tightest spot only has 180 degrees of calcium. But 10 millimeters downstream, there's a 5-millimeter segment with 360-degree calcium.
So where do you focus the modification?
You must focus your most aggressive modification tool, your atherectomy or lithotripsy, on that 5-millimeter segment with the 360-degree calcium, because that's the segment most likely to prevent full stent expansion. Treating the entire 40-millimeter length aggressively just increases risk. Intravascular imaging is essential to pinpoint that critical calcified zone within the longer lesion.
That makes sense. Target the true barrier. Now, the ultimate challenge. Chronic total occlusions, CTOs. Calcification here is a major predictor of failure, right?
Absolutely. Severe calcium in a CTO makes everything harder. It can form an impenetrable proximal cap, making it impossible to cross with the wire antegrade. Even if you cross, advancing balloons and stents through that rigid calcified channel is incredibly difficult. Success rates drop, complication rates rise.
And how are modification devices typically used in CTOs?
Usually they're not used to create the initial channel. The goal is first to cross the CTO with a wire, often using specialized techniques, maybe going retrograde or using dissection reentry methods. Once you have wire access across the lesion, then you might bring in a modification device like atherectomy or IVL to prepare that newly created channel to make it large enough and compliant enough to deliver the stent properly.
And the consensus makes a really important safety distinction about which atherectomy device to use if you've ended up in a dissection plane during the CTO crossing.
Yes, this is crucial. If your wire track is within a subintimal or dissection plane, rotational atherectomy, RA, is strongly preferred over orbital atherectomy, OA.
Why is that?
RA uses a burr that spins concentrically around the central guide wire. Its action is relatively contained along the wire's path. OA, however, uses an eccentrically mounted crown that creates a wider elliptical orbit through centrifugal force.
And in a dissection plane.
That orbit can be uncontrolled and dangerous. Deploying OA in a fragile dissection plane risks rapidly expanding that dissection, causing a large hematoma, or even perforating outwards. RA is considered safer in that specific, delicate situation.
That's a critical distinction. Okay, let's talk about failures of previous interventions, in-stent restenosis or ISR. How does calcium play a role here?
Calcium can cause ISR in two main ways. First, the original intervention might have failed because underlying calcification led to initial stent underexpansion. The stent never fully opened, so restenosis happens quickly.
The initial problem wasn't solved.
Exactly. Second, you can get calcified neotherosclerosis. This is where new plaque builds up inside the original stent over time, and that new plaque itself becomes calcified.
How common is that?
Its prevalence increases the longer the stent has been in place. The consensus notes it can be found in around 20% of ISR cases that occur more than 7 years after the initial stenting. So you end up with this very rigid structure stent struts plus new internal calcium.
And what does imaging tell us about treating this calcified ISR? Could you just put another stent inside?
Imaging, particularly OCT, is vital here. If it shows thick calcium again, that threshold of greater than a zero point 0.5 millimeters, whether it's the new neotherosclerosis or the original underlying calcium showing through, just placing another stent layer on top is very likely to result in underexpansion of that second stent.
So you have to modify the calcified ISR first.
You really do. You need to use lithotripsy or maybe atherectomy carefully to break up that calcified material within the old stent before putting in a new drug-eluting stent or even using a drug-coated balloon. Otherwise, you're just repeating the problem.
Finally, the last subset. Patients post-coronary artery bypass grafting, post-CABG. What's unique about calcification in these patients?
Well, we know that atherosclerosis can progress rapidly in the bypass grafts themselves, especially vein grafts. But the consensus points out something interesting about the native coronary arteries in these patients.
What's that?
Studies using intravascular imaging have shown that the segments of the native coronary arteries located just proximal to where the bypass graft is sewn on the anastomosis site tend to show a greater degree of calcification, more negative remodeling, and a higher prevalence of those troublesome calcified nodules compared to similar locations in patients who haven't had bypass surgery.
Why would that be?
The exact mechanism isn't fully clear, but it might relate to altered blood flow dynamics, shear stress changes, or maybe some localized inflammatory response near the surgical site that accelerates the calcification process in that specific area of the native vessel. It means you have to be particularly vigilant about severe calcium when intervening near graft origins in post-CABG patients.
Wow, that level of detail on morphology really underscores why imaging is so critical. You can't treat what you don't understand. Okay, now that we've identified the enemy in all its forms, let's dive into the weapons, the modification toolkit.
All right, this is where we get into the practicalities, the devices themselves, and the specific techniques the consensus recommends for using them safely and effectively. We can group them by how they work.
Let's start with the non-ablative options, the balloons designed specifically for calcium. Hashtag A balloons, non-ablative modification.
Right. These aren't removing plaque. They're aiming to fracture or score the calcium to make the vessel more compliant before the stent goes in.
First up, the workhorse, non-compliant NC balloons. These are high-pressure balloons used for less severe lesions or sometimes to predilate before imaging. What are their limits in severe calcium?
NC balloons rely on pure radial force. In mild or moderate calcium, they can create small dissections or crack thin calcium, increasing elasticity. But if you have really severe eccentric calcium, the balloon will preferentially expand into the softer, non-calcified part of the vessel wall.
Leading to problems.
Yes, you get eccentric expansion, which doesn't effectively crack the calcium, but does risk causing a deep dissection or even perforation on the opposite, healthier wall segment. Plus, they have a notorious tendency to watermelon seed to slip out of the tight calcified lesion because the resistance is so high.
So to get more controlled force delivery and less slippage, operators turn to cutting or scoring balloons. How do they work?
These balloons have small metal elements mounted on their surface, either tiny blades, cutting balloon, or wires, scoring balloon. When the balloon inflates, these elements create very specific, shallow incisions or scores in the calcified plaque.
Like pre-fracturing the calcium.
Exactly. It creates defined lines of weakness. This allows the subsequent stent to expand much more symmetrically, channeling the dilating force into those scores, leading to controlled fractures rather than uncontrolled tearing. And they grip the lesion better, reducing slippage.
Is there a specific sizing recommendation for these?
Yes, a key safety tip from the consensus. To minimize the risk of creating too deep an incision, potentially leading to perforation, you should generally undersize the cutting or scoring balloon by about 0.5 millimeters relative to the reference vessel diameter. The goal is to score it, not fully dilate it at this stage.
Okay. What if even cutting balloons aren't enough? Then we get to the ultra-high pressure options, like the OPN balloon.
Right. The OPN balloon is a specialized double-layer balloon designed to withstand extremely high pressures. We're talking potentially over 40 atmospheres. Sometimes even higher might be needed for truly resistant lesions. It's brute force dilation.
When do you use that?
You typically reserve it for lesions that remain undilated even after using standard NC or cutting balloons. It can be effective, achieving high rates of angiographic success.
But there must be downsides or risks.
Definitely. The main risk is vessel perforation, simply due to the enormous pressures involved. Also, these double-layer balloons tend to have a bulkier profile, which can make them harder to deliver and, importantly, harder to recross if you need to bring in another device afterwards.
Is there an undersizing recommendation here too?
Yes. Similar to cutting balloons for de novo lesions, not ISR, the consensus suggests undersizing the OPN balloon by 0.5 millimeters to try and focus the force effectively while mitigating the perforation risk.
And you mentioned earlier a general tip for any high-pressure balloon dilation, the buddy wire. Can you remind us why that's important?
Sure. When you inflate any balloon to very high pressure, especially these specialty balloons, they can sometimes stick to the guide wire as you're trying to pull the balloon back out after deflation. If you pull too hard, you risk inadvertently pulling your main workhorse guide wire right out of the distal vessel.
Reducing your access.
Exactly, which can be a disaster, forcing a difficult and risky rewiring attempt. Placing a second buddy wire alongside the main wire before the high-pressure inflation secures your distal access. If the main wire gets pulled back with the balloon, the buddy wire is still in place, and you can continue the procedure safely. It's a simple but crucial safety measure.
Good tip. Okay, let's move from stretching and cracking to actually removing the calcium, the atherectomy devices, starting with rotational atherectomy, or RA, hashtag Team B, rotational atherectomy, differential cutting.
RA uses a small, football-shaped burr coated with diamond dust on its leading edge. This burr spins at incredibly high speeds, like 140,000 to 180,000 RPM, as it advances over a special thin guide wire.
And the principle is differential cutting.
Yes. The high-speed spinning burr preferentially ablates hard, inelastic material like calcified plaque, while elastic, healthy tissue tends to deflect away. It essentially sands down the calcium into microscopic particles, typically 2 to 10 microns in size.
Which are hopefully small enough to pass through the downstream circulation.
That's the theory, yes. But the technique is absolutely critical with RA. Small errors can lead to big problems like slow flow, no reflow, burr entrapment, or perforation. The consensus is very specific on technique.
What are the key parameters operators need to follow? Burr size.
The recommended burr size to artery diameter ratio is kept small, generally 0.4 to 0.6. So for a 3.0 millimeter artery, you'd typically use a 1.5 millimeter burr, maybe 1.75 millimeter at most. Starting too small, like with a 1.25 millimeter burr in very dense calcium, paradoxically increases the risk of the burr getting stuck.
And the guide wire is special too.
Yes, it's a very thin 0.0009-inch wire, the rotowire, that tapers even further near the tip. It comes in floppy and extra support versions. Using the extra support wire might increase the risk of perforation slightly because it biases the burr more, so caution is needed.
How should the burr actually be moved through the lesion?
The technique is crucial. It must be a slow, deliberate pecking motion. You advance the spinning burr just a little, then pull back slightly, advance a little more, pull back. You don't just push it straight through.
And short runs are key.
Absolutely essential. Each ablation run should be less than 30 seconds, ideally even shorter, like 15-20 seconds.
Why the strict time limit?
Two main reasons. First, friction generates heat. Longer runs risk thermal injury to the vessel wall, which can cause spasm, dissection, and maybe late restenosis. Second, ablation creates debris. Even though the particles are small, long runs generate a large particulate load that can overwhelm the microcirculation downstream, leading to slow flow or no reflow, or blood flow stops. Short runs with pauses allow the circulation to clear.
And the consensus specifically warns about burr speed deceleration.
Yes. You must monitor the burr speed on the console. A sudden drop in speed, especially more than 5,000 RPM, indicates the burr is encountering excessive resistance. Pushing aggressively when the speed drops is the main cause of burr entrapment, the burr getting mechanically stuck in the calcium. That's a very dangerous complication. You need to back off immediately if you see significant deceleration.
So meticulous technique is paramount for RA. What about the other main atherectomy type, orbital atherectomy, or OA, hashtag TACI, orbital atherectomy OA bidirectional ablation?
OA works differently. It uses a diamond-coated crown that's mounted eccentrically, off-center, on the drive shaft that goes over a standard Viper wire. When this crown spins at high speed, 80,000 or 120,000 RPM centrifugal force causes it to swing outwards, creating an elliptical orbit.
So it sands a wider path than its actual size.
Correct, and it's unique because it ablates bidirectionally, both as you advance it slowly forward and as you slowly pull it back.
What's considered the optimal technique for OA to maximize lumen gain?
Unlike the pecking motion of OA benefits from a smooth, very slow advancement speed, typically around 1.0 millimeter per second. This slow, steady movement allows the orbiting crown more time in contact with the calcium at each point, leading to greater ablation and a larger final lumen. Rushing it is less effective.
Are there similar time limits for OA runs?
Yes, very similar rules apply for safety. Individual runs should not exceed 30 seconds to manage heat and debris. There's also a maximum total treatment time for a single crown, usually 5 minutes. And critically, the rest time between runs must be equal to or longer than the run time itself. This mandatory pause is vital for microcirculatory recovery.
Clinical data like the Orbit-2 trial showed good results. How does its risk profile compare to RA, aside from that CTO dissection plane issue we discussed?
Generally, major complication rates like perforation, dissection, slow flow are broadly similar between RA and OA when used appropriately. OA might have a slightly higher theoretical risk of distal embolization due to potentially larger particles, but large trials haven't shown a major difference in clinical outcomes. The choice often comes down to operator preference, lesion characteristics, and that specific safety concern in dissection planes.
Okay, so 2 ways to physically remove calcium. What about the newer approach that breaks it without removing it? Intravascular lithotripsy, IVL. Intravascular lithotripsy, IVL, sonic pressure waves.
IVL is fascinating technology. It's delivered via a balloon catheter, but embedded within the balloon are miniature emitters that generate controlled, pulsatile sonic pressure waves like tiny, localized shock waves.
Similar to lithotripsy used for kidney stones.
Exactly the same principle, just miniaturized for coronary arteries. The real genius is how these waves interact with tissue. They travel through soft tissue and blood without much effect, but when they hit hard, dense calcium, the mechanical stress is selectively amplified right at the calcium interface.
Creating fractures.
Yes. It generates a very high effective local pressure, estimated around 50 atmospheres, right within the calcium structure. This creates both microfractures and macrofractures, cracking the calcium circumferentially and transmurally through its thickness, making it much more compliant.
How is it delivered?
It's quite straightforward. You position the IVL balloon across the lesion, inflate it to a low pressure, typically 4 atmospheres, just enough to ensure good contact between the emitters and the vessel wall. Then you activate the device, and it delivers a cycle of 10 shockwave pulses. You usually deliver multiple cycles along the length of the lesion.
What are the main advantages of IVL highlighted in the consensus?
The biggest advantage is probably safety, particularly regarding slow flow. Because it's not physically ablating or removing plaque, it doesn't generate the same kind of particulate debris load as atherectomy. The rates of slow flow and no reflow are significantly lower with IVL.
That's a major plus, especially in high-risk patients.
Absolutely. Another advantage is versatility. It's delivered on a balloon platform, so it can potentially treat eccentric, concentric, and even nodular calcium. The DISRUPT-CAD trials showed effectiveness across these morphologies. It can also be used easily in bifurcation lesions, as you can have multiple guide wires down, which isn't possible with atherectomy devices.
Where does the consensus see its sweet spot?
It's particularly well suited for circumferential, severely calcified lesions that are still balloon crossable, meaning you can get the IVL balloon itself across the blockage. If you can deliver it, it's often a preferred first-line therapy for modifying calcium due to its safety profile and effectiveness in fracturing circumferential calcium.
Is it used in other situations too?
Yes, its off-label use has become very common and widely adopted for treating stent underexpansion, especially due to calcific neotherosclerosis inside an old stent, or for tackling those reprotruding calcified nodules after initial stenting. Its ability to fracture calcium through existing stent struts is a unique capability.
So a powerful tool, especially when deliverable and when minimizing debris is critical. What about the last tool in the kit? Excimer laser coronary atherectomy, ELCA. ####E. Excimer laser coronary atherectomy, ELCA.
ELCA uses a catheter that emits pulses of ultraviolet laser light. It works through 3 main mechanisms. First, photochemical ablation, basically vaporizing tissue. Second, photothermal effects, generating heat. And third, photomechanical effects, creating rapidly expanding and collapsing vapor bubbles cavitation, which generates acoustic pressure waves.
How does that help with calcium?
The acoustic pressure wave can help modify plaque and potentially fracture calcium, similar in principle to IVL, but less focused perhaps. The cavitation effect is also very good at debulking soft material like thrombus or non-calcified plaque.
What are its key advantages?
A major practical advantage is that ELCA catheters can be used over any standard 0.014-inch workhorse guide wire. You don't need a special wire like with RA or OA. They're also generally quite flexible and deliverable and less prone to getting entrapped than rotational devices.
But its impact on severe calcium alone is maybe limited.
Correct. The consensus suggests that ELCA alone often doesn't have sufficient impact on heavily calcified lesions compared to RA, OA, or IVL. Its niche tends to be in situations like treating in-stent restenosis, especially non-calcified ISR or where thrombus is present, or trying to cross device uncrossable lesions where bulky plaque or thrombus is preventing other devices from passing. It can help debulk a channel.
And there's that high-risk off-label technique mentioned to boost its calcium effect.
Yes, the so-called contrast burst technique. By injecting a small amount of saline or contrast through the guide catheter just as the laser is fired, you dramatically enhance the cavitation effect and the resulting acoustic energy. This can significantly improve its ability to fracture calcium.
But it comes with risks.
Big risks. It significantly increases the chance of causing slow flow or no reflow due to the enhanced debris generation and potential microvascular damage. It also increases the perforation risk. This is definitely an advanced technique reserved for experienced operators in very specific, challenging situations where other options have failed or are not feasible.
Okay, that covers the diverse toolkit, an impressive array of options, each with its own strengths, weaknesses, and technical demands.
Absolutely. And knowing which one to pick and how to use it properly based on detailed imaging, that's the core of the consensus strategy.
So let's bring it all together. We've looked at the problem, the crucial role of imaging, the specific lesion types, and the different modification tools. How does the expert consensus synthesize this into a practical, step-by-step treatment algorithm? Figure 6 in the document lays this out, right?
Yes, Figure 6 is essentially the roadmap. It's all built around this cycle of image, decide, modify, reassess.
Walk us through the steps.
Step 1. Step 1, investigate. If you see calcification on the angiogram, or even if you just suspect it in a complex lesion, you must investigate further with intravascular imaging, IVUS or OCT. Sometimes the lesion is too tight to even get the imaging catheter across initially.
What do you do then?
You might need gentle predilation with a small, low-profile balloon, just enough to create a channel for the IVUS or OCT catheter. The goal isn't treatment yet, just diagnosis.
Okay, imaging catheter is in. Step 2.
Step 2. Determine if modification is needed. Now, you apply those consensus criteria we discussed earlier. Look at the images. Is there a 360-degree calcium arc? Is there 270 degrees for 5 millimeters or more? Is it a small vessel, 3.5 millimeter? Or if using OCT, is the calcium thickness 0.5 millimeter? If the answer is yes to any of these, then modification is mandatory before stenting.
Decision made. Modification needed. Step 3.
Step 3, choose your modality. This is where you tailor the tool to the lesion based on the imaging findings. For long, diffuse calcification, especially if it's uncrossable, atherectomy, RA or OA, might be needed first to create a channel. For more focal, concentric, eccentric, or nodular lesions, especially if they are balloon crossable, specialty balloons, cutting scoring, OPN, or IVL are often preferred.
And safety factors play a role here too.
Absolutely. If the patient has, say, very poor LV function or is deemed high risk for slow flow, the lower debris burden of IVL might make it a more attractive choice than atherectomy if the lesion is suitable.
Okay, you've chosen your tool and performed the modification. Step 4. This seems critical.
Step 4. Assess the result of modification. This is crucial and often skipped in the past. You don't just assume the modification worked. You need proof. The best way is to repeat the intravascular imaging, IVUS or OCT, to directly visualize calcium fractures.
What if repeating imaging isn't feasible?
The alternative is to perform an angioplasty using a non-compliant NC balloon-sized 1.1 to the reference vessel diameter. Inflate it fully and carefully assess its expansion under fluoroscopy in at least 2 different angiographic views.
What are you looking for with the NC balloon test?
You're looking for full symmetric expansion of the balloon. If the balloon waist fully resolves and it looks nicely rounded without any dog boning or residual tight spot in the middle, that's your surrogate marker that the calcium has been adequately fractured or modified and the vessel is now compliant.
And if you don't see full expansion or imaging shows no fractures. Step 5.
Step 5. Proceed or modify further. If the assessment criteria are met, either you see fractures on imaging or the 1.1 NC balloon expands fully, then you can confidently proceed to stent deployment, optimizing it with imaging guidance as well. But if the assessment is suboptimal, the calcium isn't cracked, the balloon is still constrained, you must not proceed to stenting yet.
What do you do then?
You go back to step 3. You need to perform further modification, possibly using a different or more aggressive device, guided by the imaging findings. Maybe you need longer atherectomy runs or more IVL pulses, or maybe switch from a cutting balloon to IVL. Vessel preparation is an iterative process until you achieve adequate calcium modification. Then you stent.
This systematic reassessment-driven approach seems key to avoiding stent underexpansion.
It is. It takes more time. It requires using imaging and modification tools appropriately, but it's the strategy proven to minimize acute complications and improve long-term outcomes in these challenging lesions.
The field isn't standing still, though. The technology and our understanding are constantly evolving. What do the emerging clinical trials suggest about where we're headed? Here's where it gets really interesting.
Yeah, the exciting part is we're moving beyond just describing techniques to rigorously comparing them head-to-head in large randomized controlled trials, RCTs. This is going to give us much stronger evidence to guide device selection.
What are some key trials the consensus document mentions?
Well, for instance, there's ISAR-CALCI-2. This trial is directly comparing the ultra-high-pressure OPN balloon against IVL for lesions that couldn't be dilated with standard balloons. It's looking at which strategy achieves a better final minimal lumen diameter inside the stent.
So comparing two fracturing strategies.
Exactly. Then you have the really large ECLIPSE trial enrolling 2,000 patients. This is comparing orbital atherectomy versus conventional balloon angioplasty as the primary modification strategy before stenting. Its main outcome is a clinical one: target vessel failure at 1 year. This will be huge for guiding OA use.
And what about comparing the big guns IVL versus rotational atherectomy?
Two key trials there: Decalcify and Sonar. Both are randomizing patients with severely calcified lesions to either IVL or RA before stenting. They're looking at crucial outcomes like stent expansion assessed by OCT and also safety endpoints like post-procedural myocardial infarction, heart muscle damage. These head-to-head comparisons are exactly what we need.
It seems like the evidence base is about to get much stronger. Any other future directions?
Another fascinating area is the integration of artificial intelligence and pre-procedural imaging, particularly coronary CT angiography, or CCTA. The idea is to use advanced CCTA analysis, potentially with AI algorithms, to map out the calcium burden, predict the challenging segments, and even help plan the modification strategy before the patient even gets to the cath lab.
Like a detailed flight plan before takeoff.
Precisely. The P4 trial, for example, is comparing a PCI strategy guided by this kind of pre-procedural CCTA planning versus the current gold standard of IVUS-guided PCI during the procedure. If CCTA-guided planning proves effective, it could streamline the whole process and potentially improve outcomes further.
So the future looks like more precise planning, guided by better pre-op imaging and treatment choices driven by solid RCT data, comparing our advanced tools.
That's the trajectory. To really summarize the core message from this SCAI consensus: success in treating calcified coronary artery disease hinges completely on, first, meticulous lesion assessment using intravascular imaging to understand the calcium's extent, arc, length, and thickness. And second, the strategic, often sequential use of the appropriate modification tools, balloons, atherectomy, lithotripsy, to ensure you achieve adequate vessel preparation, ideally confirmed by imaging or a test inflation before you implant the stent. That dedicated preparation is non-negotiable for good results.
It's really clear that the days of just push harder with a balloon are long gone. The technical sophistication is incredible. Yet listening to all this, especially the discussion around challenging anatomies like CTOs, or those stubborn calcified nodules that can reprotrude, it strikes me that despite all the technology and precise measurements, there's still a significant element of art involved.
Oh, absolutely.
The operator still has to make real-time judgments, weighing the benefits of more aggressive modification against the risks of complications, perfectly tailoring these powerful tools not just to the lesion, but to the individual patient's overall clinical picture. It seems the challenge constantly forces us to refine not just our tools, but our judgment.
You've nailed it. That blend of advanced technology and experienced clinical judgment is exactly what defines modern complex PCI, especially in calcified lesions. It's challenging, yes, but also incredibly rewarding when you get it right for the patient.
An essential deep dive into a critical area.
Yeah.
Thank you for walking us through that complex landscape. Thank you for watching The Funnel Effect.